Good evening, everyone, and welcome to this webinar focused on the use of New Vision's amniotic membrane, Omnigen, in a variety of different clinical settings. Thank you for joining us. My name is Andy Hill, and I'm the CEO of New Vision Biotherapies, and it is my good fortune to introduce Mr. Saj Ahmad as your chair for this event. Mr. Ahmad is a consultant ophthalmic surgeon at Moorfields Eye Hospital NHS Foundation Trust, where he specialises in a range of areas such as keratoconus, corneal grafts, and laser cataract surgery. He received his FRC ophthalmology from the Royal College of Ophthalmologists and his PhD in stem cell biology from the Institute of Human Genetics at Newcastle University. Mr. Ahmad is also an honorary consultant ophthalmic surgeon at the Royal Liverpool University Hospital and an honorary senior clinical lecturer at the University of Liverpool. Saj, over to you.
Thanks, Andy. Thanks for the kind introduction. And I think we've got an afternoon full of a cocktail of uses of amniotic membrane by the looks of it. And we will start off with Jonathan Morton from Merseyside, who uses it as part of the Mohs service. Now, Jonathan, I think, has a pre-recorded talk and will hopefully be available for the Q&A later. So if we could just play Jonathan's slides.
Good evening. I'm Jonathan Morton. I work as a consultant plastic surgeon in the Mersey Super Regional Mohs service. And this is a presentation on our experience of using Omnigen. We're quite unusual, really. We're a team of Mohs trained plastic surgeons offering a full range of facial resection and reconstruction at St Helens and Whiston hospitals. Personally, I specialise in Mohs surgery, soft tissue facial reconstruction, and a large part of my work, at least 50%, is periocular reconstruction. So our experience of Omnigen is in 5 patients over the last few years, all of whom required extensive excision of periocular basal cell carcinoma. 2 of them were total and subtotal lower lid excisions, including inferior fornix. 1 was a total upper lid resection, including superior fornix, and 2 patients had severe recurrent medial canthal disease with involvement of the bulbar conjunctiva, but not involvement of the globe. So I'll get on with showing you the first lady. Now, unfortunately, this is the only intraoperative photograph we have, which is a bit unfortunate, but she had an excision requiring periosteum and orbital fat removal, together with the medial fornix, and as far as approximately 4 millimeters from the limbus, although it's not really very well shown on this photograph. So we used Omnigen to recreate, to reline the surface of the globe and to recreate a medial fornix. This was a tunneled median forehead flap used to cover the reconstruction once the upper lid had been medialized with a tensile flap and reattached to the posterior lacrimal crest. And the soft tissue defect between the two was resurfaced with a full thickness skin graft. She had a very good result post-operatively with a full range of movement, so I would count that as a success. This is the recreated medial fornix as best as I could photograph it with the tightness of the lids, but essentially it looks identical to normal conjunctiva as far as I can see. Yeah, she had a great result, really. Next lady had a similar problem with a large area of denuded globe from conjunctival removal. This is the only patient who gave us a complication, really, and that was because we underestimated how much tissue we were going to require for conjunctival replacement. And as you know, it comes in discs and one large square piece. We only had a disc available, and it wasn't really sufficient. And she did actually develop some restriction of lateral gaze. Once things had settled down, it didn't prove too troublesome for her after being fitted with a prism, and no further intervention was required. Moving on from there is this gentleman who had presented with a large basal cell carcinoma occupying most of the conjunctiva right down to the inferior fornix. This was resected under local anesthetic with Mohs surgery. And this is the reconstruction which we did under GA. So here we're using the square sheet of Omnigen, which is about £1,600 worth, I think. Our experience of this is that it's as fragile as tissue paper when it's dry, but does develop considerable strength when it's wet, and then becomes much easier to suture into place. The yellow arrows show where it's been aligned with the native conjunctiva, and we're attaching it with a running atovical suture. The one really big problem that we had with this is that once you've maneuvered it into place and it's become wet, it's almost impossible to relocate it. So if you don't get it right first time, it's very, very difficult. And if the whole thing becomes wet and you try and move it, it can easily become like a little ball of tissue paper, a very expensive ball of tissue paper. But this guy's reconstruction went very well. Here we're attaching the Omnigen to the frill of bulbar conjunctiva. You can see here our loop flap, which is an orbicularis propeller flap that's going to be used for anterior lamellar reconstruction. Posterior lamella was a free tarsal graft from the upper lid, and here's the conjunctival fornix recreated and inflated with a little saline to demonstrate it. Here's our anterior lamellar reconstruction in place following translocation of the flap, and this is the post-op result a few months later. And you can see the Omnigen replacement has done a really excellent job of recreating the inferior fornix. Here's the frontal view. He's got a little more scleral show on this side than he has on the other, but full range of movements. And of course, that scleral show is my fault, nothing to do with the Omnigen, just fractionally undersizing the flap. Next patient was the guy who had a total lower lid resection for basal cell carcinoma. The reconstruction essentially was exactly the same as the previous guy, with Omnigen to recreate the fornix, free tarsal graft with lateral orbital orbicularis propeller flap for anterior lamella, and again with a good result. So these two patients both had full range of movement post-operatively and no further problems. And then the final patient was a lady who had unexpectedly required her entire upper lid excision excising for infiltrative BCC, which just kept on going and going. So the reconstruction for this is a little unusual. This is a chondromucosal flap. This is basically the upper lateral cartilage from the nose that has been developed on a pedicle that includes the dorsal nasal artery. So this is a beautiful fit for posterior lamella. The cornea seems to really feel very comfortable with it. And it also provides you with a vascularized posterior lamella. So this was applied, and then the conjunctiva recreated again using Omnigen. I assume it went fine because she had a moderately good range of movement, considering most of her levator muscle had been excised. The very fact that she could open it at all and that she could close it adequately, we would count as a considerable success under the circumstances. She had sufficient vision to see, which was good because unfortunately she had a vascular accident and lost sight in the opposite eye about 7 months later. So that's pretty much our experience really of Omnigen. Our alternative choice for conjunctival replacement is buccal mucosa. And that's what we've been using for our last 3 or 4 significant cases. We've had 3 or 4 really big cases of extensive lateral orbital basal cell carcinoma. And for those, we've used buccal mucosa, both been GA reconstructions. Buccal mucosa is pretty plentiful. The only cost is the time involved to harvest it, which isn't terribly long, and the discomfort the patient has subsequently, although they do seem to tolerate it very well. I think the Omnigen is the one that is quite. I was quite surprised by just how much it resembles native conjunctiva once it's settled into place. The cost, it is pricey, but I don't think it's an unreasonable cost. But the difficulty is with what we need it for is we need a square piece, and there's only one large square piece available, and you tend to end up wasting quite a lot of it. And it is really fiddly to use. I do think that there could be a better way to identify the graft side versus the stressing side. I know it's the eye looking to the right, R equals graft, etc. But
thank you very much. So hopefully Jonathan will join us at the end for Q&A, the Q&A session, and we'll probably take questions right at the end. Manvi is going to be speaking next. So that's Manvi Sobti from Chelsea and Westminster, and I've had interactions with Manvi over the last sort of year with some of our joint patients who have severe Stevens-Johnson syndrome. And I think, Manvi, you're going to present some of your experience in using Omnigen in patients who have acute Stevens-Johnson. Thank you very much.
Hi, Sarge. Thanks a lot for the introduction. Right. So, yes. So here at Chelsea Westminster Hospital, we do have a big advantage that we work with a burns unit with an excellent intensive care team, and also have dermatology, gynecology, and ophthalmology all in-house. So we are geared up to deal with the complexities and challenges posed by Stevens-Johnson syndrome. So what is SJS intense? As we all know, it is a fulminant immune-mediated vesicular-bullous disorder affecting the skin and mucous membranes. And although these patients have blistering all over the skin, they do recover quite well with good intensive care. However, it is the acute ocular inflammation, which if untreated or poorly treated, that can lead to devastating consequences. And that can be destruction of the conjunctival goblet cells, keratinization of the ocular surface, limbal stem cell deficiency, and patients can land up with chronic severe dry eye, and they're dependent on drops lifelong, and even severe visual impairment from corneal perforation. And thus acute care is really important. Now, this interesting paper from Moorfields recently, they published on their outcomes for chronic SJS, and the patients that were referred to them with good vision continued to maintain good vision, whereas those patients with chronic SJS referred with poor vision didn't seem to really improve much. And this really puts the focus back on acute care for SJS. So what do we do here at Chelsea? So it's standard management with medical management with intensive steroid drops, preservative-free lubricants, antibiotic cover, IVIG and IV methylpred based on our collaboration with the MDT. And we use Amnion quite early on. But with the use of Amnion, there are quite a few questions as in when do we use it? How do we use it? Do we use an Amnion sheet? Do we use an Omnigen? So I'll just getting into some of these discussions. So firstly, why Amnion? Now, there's good evidence to say that acute SJS treated early on with amniotic membrane transplant can prevent or significantly reduce the ocular surface consequences. And why? And it's mainly because of the anti-inflammatory factors, the growth factors, and also it acts as a biological dressing. So it acts as a mechanical barrier between the palpebral and the bulbar conjunctiva, and it allows the epithelium to heal underneath the amnion. Which amnion do we use? Really, the preference in the early stage is to cover the entire ocular surface, including the cornea, the bulbar conj, palpebral conj, lid margin, with a nice big sheet of amniotic membrane. However, this is not always practical. If there are procurement delays or if there are logistical delays, we just go ahead and place a temporary Omnigen in, and then we can replace it with a sheet when possible. When do we do it? So this is sort of a timeline based on our case series over the past 2 years. And this tells us how urgent it is to place the amnion. One of the first signs that we see is lid margin deepithelialization. And this can be accompanied with conjunctival inflammation. But we certainly have had cases with pure lid margin deepithelialization, no conjunctival inflammation at all. And these cases we were able to manage just with medical management and close follow-up. Then you can have palpebral conjunctival ulcers, so the epithelium sloughs off, or it may remain as a pseudomembrane. But the critical sign to look for is bulbar conjunctival deepithelialization. And this is, for me, a threshold to go ahead and place an amnion. So it's important to sort of state that we place the amnion even before any corneal involvement and any symblepharon formation. That usually happens in week 2 or week 3. And really the window of opportunity is much earlier than that. How do I place it? Excuse my amateur drawings, but essentially the amnion, I take a sheet of amnion, place it on the cornea, tuck it in with a squint hook deep into the fornix, drape it over the lid margin and onto the skin. I suture it with atovitral onto the skin and onto the fornix. Now, the second diagram here, what I've tried to say is that with my left hand, I'm holding a Morpheus forceps, press down on the globe and then grasp all the soft tissues. And this should grasp the conj and the amniotic membrane. And then with a quick pass with the right hand, you go through all the layers, that is amniotic membrane and conj. And this really avoids, it allows me to quickly suture it into the fornix and avoiding the fiddly amniotic membrane. It avoids buttonholes. And also it avoids blind suturing under the amnion, trying to look for the conjunctiva. So this is done in the lower fornix and also in the upper fornix, and then put a large bandage contact lens over this. Okay, lovely. So this is the first case with obvious lid margin staining, a lot of conjunctival inflammation. The palpebral conjunctiva on the right eye is starting to slough off as well. However, the bulbar conjunctiva was still intact, cornea still pristine, well lubricated, but based on the level of conjunctival inflammation, we decided to go ahead and place the amnion. The second image is an intraoperative photograph with extensive inflammation in the fornix. And although there were no formed synechiae, it's easy to see how they could easily form synechiae quite soon. The cornea was still well lubricated. We place the amnion and you can see reduced inflammation. The conjunctiva looks much whiter. There's still a lot of excess amnion sitting there. And also note the quality of skin. With the blistering, all of the skin has got crusted. This patient did quite well. So this is end of week 2 when the amnion had resolved, the bandage contact lens was removed, and there's no symblepharon. The inflammation has settled down, although there is still some inflammation, and this was being treated with cyclosporin and steroids. The cornea is well lubricated, although the conjunctiva was slightly dry. But 3 months later, this patient is doing extremely well. In fact, they have a slight watery eye, which we don't mind. The second case was way more fulminant. So the first image you can see is on day 2 of presentation, and they had a massive deterioration between day 1 with only lid margin involvement and day 2 with extensive bulbar and palpebral involvement. We decided to go ahead and place an amnion. However, we just had one cryopreserved amnion sheet available, so went ahead and did the right eye. For the left eye, as a temporizing measure, put an Omnigen in, and then replace this Omnigen with an amniotic sheet a few days later. Initially, the patient did extremely well with conjunctival inflammation settling down well, cornea was clear, comfort had improved. However, in a span of 24 to 48 hours, they had developed large epithelial defects. So this shows how rapidly things can change with this condition. And there was initial worsening with keratitis, keratolysis, possible mild infection, but with serial placements and replacements of Omnigen, there was slow recovery. And now 10 months down the line, the left eye has done extremely well. It's well lubricated with a vision of 6 by 7.5. The right eye, unfortunately, still has a scar, but it's well lubricated and there are no lid complications. This is the last case. Apologies for just a few photographs, but this is really an unfortunate case where the patient completely refused any surgical management. And they had all the typical signs, and we had to really painfully watch the progression from conjunctival ulcers to symblepharon to an extremely dry parchment-like conjunctiva, dry cornea, and again, in a span of a weekend, they had a corneal perforation with then eventual poor vision. So really, concluding from this, our acute management of Stevens-Johnson's includes early use of amnion, and we do this before the cornea gets involved, before any symblepharon formation. And the key thing that I look for is any sign of bulbar conjunctival involvement, and that's our cue to go ahead and put amnion. This condition needs intensive monitoring because we've seen dramatic changes occur. And it's useful to have a timeline, that is in week 1 to consider amnion. In week 2, once the amnion disappears, based on the level of inflammation, do they need a replacement? And to week 3, to closely watch for corneal changes. And of course, it's our multidisciplinary management at Chelsea. And of course, as Saj said, we phone a friend. Okay, thank you. That's my talk.
Thanks very much, Manvi, for a fantastic series of cases. And for those of us who manage Stevens-Johnson, we know how difficult it can be, especially in the acute phase. Managing patients with amniotic membrane when they're in ITU isn't an easy task. So thank you very much for sharing your experience. Next, we've got Amit Arora, who's one of our colleagues at Moorfields Eye Hospital and also has a joint position at Barts Health. Amit's got lots of experience with the use of amniotic membrane in surface tumours in particular. So I'd like to ask Amit to present his talk if possible.
Hello everyone, and thank you for the opportunity to speak today. So I work as an ocular oncologist. So I'm one of a small team here at Moorfields, and we look after predominantly malignant tumours of the surface of the eye, not including the eyelids, and tumours inside the eye. And we do both adults and children. We are one of only 4 specialist centres in the United Kingdom. I think we're still the biggest and certainly the oldest unit of this kind in the UK. So my role with using Omnigen started back around 2018, if I remember rightly, before the pandemic hit. The first time we used it actually was by pure chance. I had 2 cases booked on an operating list on a Monday to find that the storage fridge for the frozen graft material had somehow broken down during the weekend. So we were forced into finding an urgent replacement. And I was given my first piece of Omnigen at the time. As some of the others have spoken, it comes dehydrated in a little packet and has to be wetted. What my theatre nurse didn't realise was actually if you put the fluid directly into the plastic container, the little piece rolls up completely and it's completely useless. So we had to rush down and get a second one out. And we've been using it pretty much now for the last 4 years. So I thought rather than go through some of the things that Manvi's already said, we'll have a look at some of our outcomes. So it gives you an idea of the outcomes we've had and what we've learned from it, really. So if I may share, hopefully this works. There we go. So this is the first outcomes that we had, and we presented it at what's called the Sequin meeting. So every year, all 4 units from the United Kingdom get together to discuss our numbers over the year, what we've done, how many patients, and present audits from our individual groups. So this was first presented, this part of it, in 2019 at the meeting in Sheffield. So at that point, when we audited this work, we'd been using Omnigen for about 10 months. So October 2018 up to that point. And we performed 20 grafts in 19 separate patients. We do all of these at Moorfields in City Road in central London, basically because the Omnigen graft isn't available at St Bartholomew's or the Royal London hospitals, where I also work. But most of our operating is done at Moorfields. This was based on 5 surgeons at the time. That includes consultants and fellows in that 10-month period. So for us, we looked at the indications for our surgery. So 5 patients were given Omnigen as part of their primary surgery, and 14 really in recurrences. And as you can imagine, most of my work is predominantly based on malignant tumors. So the biggest group are malignant and pre-malignant disease. You're looking at really conjunctival melanoma, a condition called CIN, which is conjunctival intraepithelial neoplasia. It's like a halfway house, not quite cancer, not quite normal. Squamous cell carcinomas. PAM is primary acquired melanosis, which is the same as CIN, but for melanoma pigment cells. And we had 1 case of surface lymphoma, amongst a few other bits. So with our surgery, the goal is to remove the tumor. So we use what we call a no-touch technique. So you try and avoid touching the tumor and the non-tumor side of the conjunctiva. So you're not risking spreading potential tumor cells. We have a 3 to 4 millimeters at least of margin. So the excision can be quite large. We are lucky to have multiple sizes of Omnigen here at Moorfields. And because it's dehydrated, it's available in our eye bank, and we could bring it up in the middle of an operating list if you need to. So over the patients, most require the sort of 15 to 25 millimeter discs. We're unlikely really for conjunctiva repairs to need much bigger than that. So this was a look at the first set of patients we used. And surprisingly, quite a few ended up having complications. Only 8 out of the patients we would say had a normal post-operative course, which of course is not very good. 11 patients had some form of complications. 1 was actually during the surgery. It's not the one that I spoke about earlier, my first case. We had a couple of patients where they had problems which we call immediate, within 48 hours of the surgery. For most people, it was at least 2 weeks later. The patient who required a second graft on the table was because we found that the amnion didn't really adhere very well to the conjunctiva and came off. We had 2 more where it happened within 48 hours. Now, the way we started doing it was we use a fibrin-based glue called Tessil. And it comes in a little applicator with 2 components. I think I might have a photo, there it is. And the 2 parts are in 2 individual halves. You squeeze the handle together and it merges the 2 and comes out the end. But immediately as this comes out, it forms a sort of fibrinous mass very quickly. And I think that was the first issue we've had with these patients. It's how to use the glue properly. And I think with these ones, we haven't done the gluing very well. And that's why they have failed to adhere. 3 patients ended up having conjunctival defects. So here, either that the Omnigen was too small, or in reality, again, the gluing hasn't been done properly and they've started to come off a few weeks later. Biggest problem, it turns out, was scarring and symblepharons. We use a scleral ring, which looks like a large plastic polo mint after the surgery. So it's placed between fornix to fornix, covers over the surface of the eye, and it has a big central hole so the patient can still see through it. It's there to protect the surface of the conjunctiva while the amnion is in place, and to protect the eyeball from trauma from the eyelid itself. But again, we found 3 people started developing scarring despite the ring within a month, and 1 almost 6 months later. They didn't all require treatment. Only 1 actually required to go back to surgery to have the fornix reconstructed. But 1 patient that developed a sort of granuloma, and this was a patient who had a suture in, treated just with topical steroids. A couple of patients we felt had quite prolonged conjunctival inflammation after the surgery, required longer topical steroid use than we would have done. But that may also be part related to cryotherapy, because we freeze around the tumor margins once it's been removed to try and kill any cells that you can't see and reduce the risk of local recurrences. So it's hard to know that it was related to the cryotherapy or the amnion of the surgery itself. And 1 patient developed a localized conjunctival cyst, which dissipated just with topical steroids. So out of the original batch, majority of them had just glue alone. Then we realized that actually it's worth thinking about suturing. So the last few patients started to have atovitral sutures to help tether the amnion in place. And you can see actually the complications. There are certainly less complications in patients with sutures, because we learned from that. And we had 3 patients where we felt the graft failed. It just hadn't done its job. It may well have just fallen out. Patients, as it heals, it's hard to be completely sure the graft is still there or not. But we think 3 patients who were glued probably failed proper grafting of the conjunctiva, lost its graft, I suspect. The other problem with oncology work is there a risk of relapse? And I think in reality, the relapse is related to the disease and not the use of Omnigen. These patients have surface conditions that can recur both locally and at distant site in the eye. So with the CIN grade 1, which is the lowest level of concern, we've had a patient where it did reoccur, but at a different site, a couple of months after the graft was done. CIN 2 or 3, which is more the sort of middle grade, occurred in a patient both in the same site where the surgery took place and a distant site. CIN 3, which is the most aggressive precancerous type, occurred in the same location as the original surgery at 6 months after treatment. 1 patient with squamous cell carcinoma, again, had both a sort of same and different site. And we had 1 patient who had a conjunctival melanoma that reoccurred at a different location. And these are usually patients with primary acquired melanosis. Their risk is there whatever you do in reality. So across those groups, the relapse time was about 3.5 months almost, ranging from up to 6 months. If you look at the correlation between the number of complications and the month they happened, basically it shows most of these complications occurred in the first cohort of patients. As we learned to use the glue properly, as we learned to start suturing some of these grafts in to help secure them, our complication rate has gone right down. And that's a good way of looking at it, this graft. How the number of grafts in green, complications in red, and as you tail on towards the end of that 10-month period, it becomes green only. So from this, we learned that actually symblepharon is still the biggest problem. And we have to think of ways to try and reduce the scarring affecting patients. problems, as particularly the 3 cases of graft failure, were related to patients who had glue only. That's changed as well. Luckily for us, there was no significant difference in outcomes in these patients, and that's just the disease process they have. So it's reassuring to know, even though we've had some complications, it hasn't seemed to make any difference really to the risk of recurrences or spread. It seems to be fairly separate to what you do. But there was a learning curve, and you can see that again as you look at the complications over time. They went down considerably, sort of 6 months into our experiences. So like any audit, you look at sample sizes. We don't have that many, but 20 is not 19, 20 is not bad. Follow-up was only a relatively short period at that point. So the whole point of audit is you make changes and you look again and see, have you made a difference? So we did a second audit to follow on from this one for the next 20 graphs. And that was about 9 months in that period. And happily, I can say, well, the number of normal post-operative cases went up considerably. So we're now at 75% at that point. 5 out of 20 patients that had complications, and now none are intraoperative. We figured out what to do. None were in immediate 48 hours. Again, it was sort of later delayed after 2 weeks. And that were the 5 patients. All 5 were glued. I mean, this is an audit of lots of different staff members rather than just one person. So there's some variations between techniques between us all. But the ones that were sutured, we've had no complications as such. And we've had no graft failures either. 16 of those patients, thankfully, so far have no relapses, which is very reassuring. So 4 patients have had relapses. Again, that's really related to their disease process. Over the years, we have also supplemented these patients with topical chemotherapy. And we've always done local radiotherapy in certain cases. So I think all of that mixed together, proper surgery, reconstruction, adjuvant, radiotherapy, chemotherapy, has helped reduce the rates of local recurrences in these patients. So symblepharon is still the most common problem, and I hope we're getting better. We haven't had any, so we know graft failures are higher with glue-only technique. 1 lost graft that we're aware of. So 4 was symblepharon, 1 was a lost graft. And hopefully we're learning. One of the changes I made with the use of the Tesil glue is not to use that applicator as it was. I now separate the 2, put 1 side of it, so to speak, on the conjunctival tissue and 1 on the back of the graft, and then stick the 2 together. You don't get the same matting and mess sometimes. I think that and the use of sutures are the biggest changes we've made. I'm very pleased with Omnigen. So far, so good. Thank you.
Thanks very much, Amit, for a fantastic overview on the role of amniotic membrane in surface tumours. So I'll now ask Mayank to present his experience on the role of amniotic membrane in stem cell treatments. And Mayank, you will know from Sussex Eye Hospital in Brighton, where he's one of the corneal surgeons there. Thanks very much, Mayank.
Thank you, Saj. Can you hear me? I guess you can. So thank you, New Vision, for inviting me to talk about the simple limbal epithelial transplant with Omnigen, because that was a new experience for us. And I'm going to briefly talk about that experience with you. These are my unrelated disclosures, apart from the New Vision Therapeutics here. Now, for the audience who doesn't know what is SLET, SLET stands for Simple Limbal Epithelial Transplantation. This was originally described by Sangwan et al. In 2012. This is the video from his own publication in BJO. This is his technique. And I'm just showing you this video as an introduction to this technique. So what he suggested is in patients with stem cell failure, where there's total conjunctivalization of the cornea, you would normally do a peritomy like you normally would, remove the conjunctiva as much as you can, then place the amniotic membrane on the cornea, but then that is glued to the surface of the cornea. So this is a fibrin glue on the surface of the cornea, and now the amniotic membrane will go on the top of the glue. So the membrane is glued on the surface of the cornea. He would then sprinkle the surface with the limbal stem cells, pieces taken from the other eye of the patient. In other words, autogenic transplant, and that works better. You can also do allogenic stem cell transplant, which is what we normally prefer at Brighton. So once this membrane is in place, I'm just going to fast forward that. These are the pieces of the limbal tissue taken from the other eye of the patient, and he's sprinkling that on the surface of the membrane, which is glued to the surface of the cornea. Then he places a bandage contact lens, and then that's the end of the procedure. And this works very well. Now, we at Brighton decided to think differently, and I think this was a fantastic innovation by Virender Sangwan. But then, why to place the pieces on the membrane, and the pieces will rub against the bandage contact lens and eventually fall off. So we modified the technique, which is published in the literature.
Cadaver cornea, as shown.
And I'm going to show you that modification of Sangwan's technique. This was a case of total limbal stem cell failure. We did the pieces from an autogenic graft we had. So we cut out limbus from the autogenic graft. This is removal of the conjunctiva from the surface of the eye, as you can see here. And once we've done that, let's go and fast forward that. We place large pieces of limbal tissue, not small ones, from allogenic donor, not autogenic, which means a cadaveric donor, and then place glue on top of these pieces and then the membrane on the top, so that the pieces are retained on the surface and they're not rubbed away by the contact lens which goes on the surface of the eye. And this we call as modified allogenic simple limbal epithelial transplantation. And this works very well, which is what we found out. And I can show you the results of this patient. This was before, and this is 3 months after SLET. Of course, there will be some scarring, and the patient then needed a gas permeable lens to improve the vision. Now, this was with the wet membrane, as you saw, and this was published, I think, in 2017, if I'm not mistaken, so a few years ago. We never thought of using Omnigen for this purpose. Now we had a case recently this year. This is the background of this case. 46-year-old patient presented to eye casualty with chemical injury, which was a descaler burn, very young female in the right eye, in January 2002. Initially managed within the casualty department with topical steroids, antibiotics, lubrication, and Omnigen, Omnilens done in the casualty, which didn't work very well, and then was referred to us in the cornea clinic. The vision was only count fingers at that stage. So this was a picture when the patient came to us in the cornea clinic, several pictures of the same eye. Essentially, you can see a limbal whitening or ischemic kind of picture there. You can see that somebody has tried Omnigen under the contact lens, half of which has slid downwards in the first picture here. And you can also see that the fornix has got some inflammation and potentially some early signs of symblepharon or threatening to go in that direction. So we redid the Omnigen in the clinic a couple of times, I think, and followed the patient up. The patient reasonably healed, but then ended up with recurrent epithelial defects. And this is an example of the defect. To the right, there is a picture which is not stained, but you can see clearly on the side here that there is a small defect, and she ended up with defects all across the cornea, not on the side of the cornea. And this was a regular phenomena. Every 2 weeks, she would present with defects. And there was pannus formation all across 360 degrees of the cornea. As you can see, very fine pannus. The vision was still count fingers because of ongoing inflammation. So we decided to do an SLET, as this was a mild case of stem cell deficiency. And this time we decided to use Omnigen because the wet membrane, first of all, is, I think, slightly more protracted to procure nowadays compared to getting Omnigen within a couple of days. And secondly, it's much more fiddly to use the wet membrane compared to Omnigen. I'll show you the video here. So when we start the SLET process, this is how we make the small pieces of the limbus. This is allogeneic tissue from a donor, not the patient. You can also use a patient, but this is a 46-year-old. We don't want to work on the good eye, and the patient refused to work on the good eye, and they only wanted us to fix the eye which was in problem. So these are the pieces of limbus. So before you start working on the pieces, just make large chunks, making sure that you don't touch or crush the limbal tissue here. Once you made strips of that, you then have to dissect it like a deep anterior lamella keratoplasty, and you can use any blade of your choice, but you do need an assistant here to hold the tissue like this. Here I'm using an MVR blade, but you can use a crescent blade, or you can use a 15 degrees or 30-degree blade to slice the tissue. Again, when you hold the tissues, either use the corneal side or the scleral side, but don't touch the limbus. And once you've got the limbal tissues, you can then cut it into very tiny pieces. But as you see, these are quite bulky, chunky pieces compared to what Sangwan originally described. And this is now the patient. Once you've done the pieces, you can see the stem cell issues there and pannus formation in the periphery. We clear the epithelium and the pannus like we normally do, and with the crescent blade, we just clear the surface of the eye, do the peritomy as I described earlier, clean the limbal part of it. And we are using the same modified technique here, which I described with the wet membrane earlier, and we published on this. But here, instead of wet membrane, we'll be using Omnigen. So pieces placed on the surface, larger than what Sangwan described. Larger piece, we believe, will give more supply of the cells compared to small, tiny pieces. And this is allogeneic tissue, so we are not sure about how many cells will still be alive in these cadaver allogeneic tissue, but if we provide a good number with the large pieces, then it will work better. Now, when you do the fibrin glue, it's very important to actually prime it next to the eye before you put a blob in. Otherwise, you end up with a thick blob going in and sticking to the glue. And as soon as you get the glue on the surface of the eye, waste no time in putting the Omnigen in, otherwise it becomes slightly messy. Also, the Omnigen, as you see, has got a tendency to wrinkle and fold. So you may need both the hands to hold it, otherwise it will just curl around, and that creates a bit of a problem. You can also put a drop of water at this stage, or BSS, to just flatten the Omnigen nicely on the surface. But this eye had a lot of fluid on the surface, including blood, so I just decided to use that and gently iron the membrane on the surface with the pieces on, and you have to tuck it under the lids as well. This is a 20 millimeter, I think this is a 20 millimeter disc, which we have used here. And you can use different sizes based on the fornix. You can also use other sizes of membrane to reconstruct the fornix if the symblepharon is still there. So once you've ironed out the membrane on the surface, you then use the Omni lens on the surface of the eye, and that will be the end of your case, actually. So once you place the lens, which fits in nicely there, as you can see, and which comes with the membrane, and tuck it in nicely before you remove the speculum, and just gently remove the speculum so that the lens and the membrane doesn't come off. I normally tend to pad these eyes for at least one night and then gently open them the following day and give them a shield so that they don't rub the eyes. Gently remove it like so. That amount of blood and plasma around it is useful, so I don't normally clean the eye, just leave it as it is, and it'll just dissolve by itself. So this case was only done about I think 4 to 6 weeks ago, and these are the pictures taken 3 weeks post-op in the clinic. The patient's due for another appointment on Thursday, which is 2 days from now. We will see that, but actually, as you can see, the cornea has cleared. There's no new pannus formation. And the bottom line is the dried amniotic membrane works as well as a wet amniotic membrane in SLET cases. So I think from now on, I may just use these for SLET. So that's it from me. Thank you so much for listening.
Thank you very much, Mayank, for your experience on Omnigen in Slack. That's some nice videos there to highlight everything. So I think we've got 2 questions. I've got a few questions as well, but let's do so from those observing. So this is for Jonathan. I think Jonathan's with us.
Hello, hi there.
Hi, Jonathan. Hi. This is just a question from Antonella, just asking about fornix reconstruction, the role of amniotic membrane versus, I assume, buccal mucosa, or but she's wondering if you've got any experience on one versus the other.
We've got more experience of using Omnigen than using buccal mucosa, to be honest.
Right.
The early cases we used Omnigen for worked extremely well. I think the one that didn't work well was probably our more to do with us than the Omnigen, really. A little inexperience and not realizing quite how much we would need. But the cases we've used Omnigen for have been excellent. The difficulty is the problem with maneuvering it. You know, you can either move it or you can suture it, but you can't. Once it's wet, then it's so difficult to do anything with it. So you really got to position it accurately. The cases we used buccal mucosa for, we needed extensive amount, really, a lot of tissue. And those were both, we had 2 really bad cases around December last year. And they've done very well indeed as well. So I really couldn't say the difference between the 2. Each has advantages and disadvantages. Yeah, great.
Do you use fornix sutures, or so once you've got the amnion in, do you just glue it in?
No, I didn't use any glue at all. I just sutured the free end to the bulboconge, and the other free end to the undersurface of the posterior line of the tarsal graft.
Right.
And then covered it all with the orbicularis flap.
Right.
So once you got the flap in place, then you've got 2 raw surfaces, and they're going to stick together
anyway.
Probably anyway. So we didn't do anything. So I was listening to Amit talking about the TISSEAL and wondered whether you know the experience of not using a TISSEAL at all, just suturing it. Maybe, I don't know.
Fantastic. I think Amit's on, so Amit might want to answer some of for that. Jonathan, Amit, do you have any experience of doing any of it without the glue and just sutures? Because obviously I had glue and sutures, but not, and glue on its own, but not sutures.
Yeah, not really. I think we've always preferred to use now the combination of both, because we are covering, you know, bare sclera, which we want to cover. We don't want to leave that exposed, and that was the problem. The graft tended to shift with the patient rubbing the eye, moving the eye, and so on, despite the little scleral rings in place. So I personally, I feel a little bit better now to use the combination of both. But with the TISSEAL glue, as I say, we've now, I'm giving sort of the 2 agents separately and not mixing it in the same syringe.
Yes.
That makes it harder.
Great, thank you. Thanks, Amit. So there's a question from Fadi and for Mayank. And this is about how you order tissue. And I assume you were using corneous eye bank tissue rather than fresh tissue.
Yes, that's correct, Sahaj and Fadi. Fadi, I normally align my cases next to either PK or DLK on the list, ideally, or DMAC even. And that helps actually to procure the limbal tissue. I think the other question which has been asked by Des Ekine is what happens with SLET pieces later? Well, SLET pieces will eventually become thin and they will either shed off, or when you remove the contact lens, when the epithelium is intact, they will come off. So you don't have to worry too much about that. They eventually disappear in 2 months or so, but leave the lens as long as possible. You will see the epithelium under that cover the limbus, and make sure there's no pannus formation. Otherwise, that means your stem cell transplant is failing, and then you need to react promptly.
Fantastic. And that was obviously an allogeneic case. Did you use any specific immune suppression, or
No, just intensive dexamethasone drops, and I also give subtenon or orbital flow Kenalog in some of these patients with intense inflammation.
Right.
Occasionally, I think I've used prednisolone orally, but nothing fancy apart from that.
Yeah. Okay. Great. Thank you. And Manvi, I had a question for you if you're still on.
Yes.
It's just regarding the amniotic membrane being in ITU. Do you normally, we've been trying quite some time to have it available in ITU in case we obviously head in, because otherwise we're having to order tissue, which then takes a little bit longer. And I can't remember what you have at Chelsea and Westminster.
So we do have a freezer, and because they have a lot of allografts in the burns unit, so we tend to have at least a piece or two of cryopreserved amnion sheet. So in that case, we're lucky, but we've after the last case, we make sure that we reorder once anything has been used up. Because when we need it in a matter of 12 hours, not 2 days.
Yeah.
That 2 days is too long, and then either just temporarily put an Omnigen to buy time, really.
Yeah. Great, thank you very much. Thank you. And I think there might be one last question from Deepti on it's gone a bit in which case is a BCL generally used along with Omnigen, and for how long? I assume that's for Mayank probably, because
Yeah, I can answer that, Saj. Omnigen comes with OmniLens, which is actually a BCL for Omnigen.
Hello. Oh, I think Mayank's just either I've gone or Mayank's gone. One of us is frozen. So, Jonathan, can you hear me?
I can hear you.
Oh, fantastic. So, Mayank, you're back. You had a little break in.
Oh, sorry. I was just saying that OmniLens is a BCL for Omnigen. It's a custom-made BCL for Omnigen so that it stays in place. If you try to use a normal BCL with Omnigen, the Omnigen will slide downwards and probably come out, and you'll just end up with the BCL. So I think I would suggest using OmniLens with Omnigen all the time.
That's interesting, because our procurement has never given us OmniLenses. So we've been forced to use BCLs, and most of our patients have been supine. So I haven't seen that phenomena yet. But yeah, that's a good point.
Great. Thank you very much to all the speakers this evening for taking time out of their evenings to share their cases and experience with everyone. And thank you to the audience. So I hope you all have a good evening. Bye-bye.
Thank you. Bye.
Thank you. Bye-bye.